Hello and welcome everyone. Today we'll be doing a literature review of this particular article, that is aspirin in treatment of patients with sepsis and septic shock. This is a phase 2 placebo controlled RCT which has been published in Critical Care Medicine last month. This study evaluates the impact that this drug is going to have on organ dysfunction. The clinical importance of the question lies in that sepsis is one of the leading causes of mortality in the hospitals, and inflammation and coagulation are key mechanisms in sepsis related organ dysfunction. So the knowledge gap that we see in this particular topic is that anticoagulation in sepsis has shown mixed results. Limited data exists on the specific role of aspirin in modulating inflammation and coagulation. So the hypothesis was that the aspirin may reduce the organ dysfunction, severity and improve outcomes in sepsis. So the primary outcome of the particular study was to evaluate whether the aspirin reduces organ dysfunction severity in septic patients, with the secondary objective to assess the safety outcomes like the bleeding risk, the transfusion needs, and evaluate other clinical outcomes like ICU free days, mortality, renal replacement therapy needs. So the study design was, it's a phase 2 double blind placebo controlled RCT. Now it was conducted across 5 general ICUs in Brazil. The population was adults with sepsis, that is less than 48 hours, with severe organ dysfunction, lactate more than 4, platelet less than 1 lakh, PF ratio less than 200, or septic shock. Now, exclusions being pregnancy, high bleeding risk, or end of life care. In this, the intervention was the aspirin, which was given as 200 milligrams per day for 7 days, and the placebo group was an identical looking medication. The outcome measures that were primarily what they were looking for was change in the organ failure, that is the SOFA score from day 0 to day 7. Secondary outcomes being the clinical ones that we have described, as well as the adverse effects of the drug. In the statistical analysis, the sample size was calculated to be 218. 166 enrolled due to safety concerns, because the safety concerns were raised, so they didn't enroll more than 166. Adjustment of the analysis was done for the age, the baseline SOFA, and the admission type. Interim analysis were done to look at the safety at 70%, 50% and 75%. So the eligibility, 1017 patients were assessed. Out of this, they excluded 850, which is a pretty large amount, because nearly 200 patients were already on antiplatelets. Many were having a non-functional GIT, so they couldn't be given a tablet. Active bleeding was ongoing in 100 patients, and there were various other causes which resulted in not giving this particular drug. So if you look at the eligibility, a very small percentage was finally eligible. That was 167. 83 were in the aspirin group, 84 in the placebo. One withdrew consent in the aspirin group, so resulting in 82 patients. So the intention to treat was this. Again, a patient failed to receive the medication, so the intention, so per protocol, 81 patients were there. If you look in terms of the demographic profile, there was not much difference between the two groups. The age was around 60 in the both groups. Female sex was around 40%. The race was basically similar, with more white patients over here. And the time of ICU admission to randomization was 1 hour. And the typical, the type of clinical admission was mostly medical. And the comorbidities again were very similar between the two groups. So if you look in terms of the outcome, then there was no major difference between the two groups, both in terms of adjusted as well as the other analysis. In the secondary outcomes, they also could not find much difference between the two groups. All clinical outcomes were essentially similar. Even the tertiary outcomes were essentially similar. But if you look in terms of the subgroup analysis again, the result doesn't seem to favor any particular group, and it is essentially similar between the two groups. No major difference. Even the subgroups are not showing anything significant. If you look and go back to the adverse effects, then there was a significantly more adverse effect seen in the aspirin group, where they did find more bleeding, as you can see here. Significant non-GI bleeding was seen. Again, serious adverse effects were also more in the ASA group, which was again bleeding again. Even transfusions were roughly similar, but then more transfusions were done in the uh, aspirin group, considering they were bleeding more. If you look at the discussion, then the interpretation is that ASA is not really impacting anything on the organ failure, but it does add an increased risk of bleeding. The comparison in the literature shows there is a conflicting results, especially from observational trials. Similar studies have been attempted in COVID-19 with no benefit. This particular study had the strength of methodology, that is RCT design, the balanced baseline character. It does have its limitations, that is the study design has some issues, that is premature termination was done, which reduces its power. The sample size, few patients were planned due to safety concern. Generalizability is definitely lacking because it's a single standard study predominantly on ICU population. Confounding factors are higher baseline prevalence of heart failure and CKD with the ASA group. Conflicting interests being industry funded and potential bias could be there. So to conclude, ASA did not reduce the sepsis-related organ dysfunction. It increased the risk of severe bleeding. Clinical use in sepsis is definitely not recommended, at least based on this trial. So regarding the clinical application, its use in sepsis is not supported. Though we can look at subgroups where there probably could be a lower risk of bleeding. But the discussion points that we can have is, should aspirin be reconsidered in any specific subpopulation like COVID-19 or lower GI bleed? The study limitations were they significant enough to warrant another trial? And could a lower dose probably could have resulted in different outcomes? And how does this trial actually impact anything of the sepsis management guidelines? Thank you for your patience.